Article 32 of the Constitution also states that every person has the right to freedom of conscience, thought, belief, opinion. And actually, sometimes we ask ourselves that certain people who come to our hospitals, for example, Jehovah's Witness, and we offer them blood transfusion, and that's a very famous, quotation in every medical, ethical, actually, discussions. Article 32, again, subsection 4, it says that no person should be compelled to act in a way that is contrary to their belief or religion. And that now goes back to, if we offer somebody and they don't want blood transfusion, have we not really infringed in their constitutional right under the current constitution? Then the other important document, which we must actually refer back, and all of us, we can access it, is the Kenyan National Patients' Rights Charter 2023. If you check section 8, it says that the right to informed consent must be given in full. There's a reason why they have said they are in full. And it must be accurate information in a language the patient understands. Now, language here, we're not talking about different tribes' language or language Swahili, or this person doesn't speak this language. We are talking about even medical jargon. We must use a simple or simplified English language. They have the right to understand about the treatment and risk and alternatives. Here, alternatives court have really insisted that the patient must be informed about alternative. There's a case we have seen some time back. The patient was informed about treatment, was informed about risks, and he argued that he was not told about alternative. And that's why he was forced to go for this procedure. And actually the patient has won that case. They must be informed about the duration and the cost of that procedure. Then there's another document, Health Act, Section 8 again. It is more or less the same of, patient charter document. It says that doctor must inform patient about their the updates of their health status. We must inform the range of diagnostic therapeutic options, benefits and risks, and must inform the patient's right to refuse treatment and the consequences of such treatment refusal. And that's why we have DAMA and LAMA. And actually, these are very important documents. I've seen them. If a patient, you feel like he might really collapse or he might get complications, some hospitals, they don't want to spoil the relationship, but you can assess, because the legal aspect, patients are really increasingly becoming legal these days. The special circumstances which can exempt you from, we know all of us that is that if the patient cannot give informed consent, they must, have a legal representative in the form of a guardian. In our African traditional setting, either the elderly son or your brother, even the wife, they have been there. Sometimes the court can grant forceful treatment for some patients specifically. In public health setting, the courts, public health officials can get a court order, somebody to be treated by force, specifically if that's infectious disease. It doesn't happen, I've not seen it in many cases here in our setting, but in the developed world, a doctor or hospital can go to court and actually get court order for a minor to be treated whose parents are refusing this treatment. And the doctor assumes, temporary, guardianship or responsibility until that treatment is over. The ethical basis, I'll go through it very fast without wasting time because we know it. The principles of autonomy and malfeasance, the principle of beneficence, and the principles of justice and fairness. This one we have learned, all of us in medical school, and these are very important principles. Beneficence means all physicians and doctors, we have to act, whatever we are doing, for the benefit of the patient. We must promote their goodwill and prevent harm. And all medical activities we are doing, we must do in the best interest of the patient. But there's also non-malfeasance, means that obligation on physicians to avoid harming the patient. Of course, no physician or doctor will harm patient intentionally, but we must take precautions to avoid harming patients unintentionally. Of course, Hippocratic oath. If you go through it, I don't know if this document is used these days in terms of swearing of doctors, but it says that, you know, a section of it, I will never use my knowledge to injure or wrong my patients. And sometimes, you know, malfeasance, there's the issue of, you know, euthanasia. Euthanasia is actually harming patients. But some quotas, they have argued that euthanasia is actually doing something good for the patient. And that's an open question. Is euthanasia, doing euthanasia is the best interest of the patient in some circumstances? I will go through this one very fast. The reason is that informed consent was not just born. It was not something decided by doctors. It was not something came up with by doctors. Informed consent has its own military background, in the sense that in 1930s and in 1940s, the Nazi physicians during the World War I and II, they have captured so many, you know, unfortunately, Jewish prisoners in camps, and they have used those prisoners forcefully without consent, and they have done experimentation on them. For example, there was one, they have collected almost 1,000 sets of twins, and they were doing something, they were calling it, you know, testing if this twin, you know, is surviving a certain experimentation compared to the other one. This one, why didn't he survive? They have actually done unimaginable things, which is difficult actually up to now, the whole world to talk about it, because amputations of people to see how nerves recover, and they wanted to use that one for their soldiers who were injured in the battlefield. They have actually done experiments which are very, very, very hard. Head injury experiments, somebody's head is, you know, smashed with guns or something, and they just want to study how does the brain behave, you know, how long does it last somebody to stop bleeding on their own, and putting some people in a very freezing environment. A malaria experiment was done, hepatitis, viral, and even sulfonamide, and even starvation and dehydration. And these are the Nazi physicians who were put on trial, actually. They were brought to court after the World War II has ended. And the courts actually, as you know, made two judgments. One for the, you know, leadership and military leadership, and that is actually called the Nuremberg trials, but the other one was the doctor's trial. It's called the doctor's trial. It was actually named the doctor's trial because the world has realized that the doctors have committed equally very bad atrocities against patients, just like Hitler, whatever, they have killed so many people, but doctors have also killed so many people during that time in the camps in the name of experiments and science. But there's another one, which some of us, or many of us, we are familiar with, is called Tuskegee syphilis studies. And here what happens that, you know, it has happened in 1932 to 1972, mainly, you know, so many Black Americans were collected who already had syphilis. And the study, you know, scientists wanted to study this person who has syphilis already. We want to study them, the natural, you know, history of syphilis without treatment. If we don't give them treatment, how do they end these patients? And it was a major scandal in America. In 1997, President Clinton actually had to formally apologize to the African American community for that illegal experimentation. But after the World War has ended, and that's when we have realized, specifically the world at the time realized that the atrocities doctors have committed. And that's why the Nuremberg trials were conducted. The Nuremberg trials were the trials for military and political leaders. But the doctors' trial was for the doctors only. They were separated because the what they have done was equally bad. Yeah? After that is when the world has come together and they have decided we must come up with something. And one document which came out of that was the Helsinki Declaration. The declaration was adopted to handle, the growing concerns of unethical medical practice during the World War II. And it says it has so many points, but 2 points. Two of them, it says that I will respect the autonomy and dignity of my patient. We have seen that one. And I will respect the secrets of confined in me, even after the patient has died. And that's actually informed consent. It has those origins. And after the war has ended, those criminals, both doctors and military, were tried. A document called the Nuremberg Code came out of that. And actually up to now, that document is used around the world, specifically people who are conducting experimentation on human beings. It has so many points. For example, voluntary human consent is very important, specifically after what has happened, what has the Nazi physicians have done. And the points are many. You can go through it. Human experimentation should not result. It should result for the good of society. For example, there must be, we must avoid all unnecessary mental and physical suffering. No experiment should actually be carried out if it is going to result in death. And these people have actually killed subjects because they wanted to see what the science will produce. And actually the last point says that terminate experimentation immediately. Results are known. Yeah? That is the historical, legal aspect, but what about, other forms of informed consent? In the hospitals, we use DNR. DNR is a form of informed consent. It can be initiated by the doctor. It can be initiated by the patient. Mainly it's in our setting, it's initiated by the doctors. Yeah? But the patient must accept. The patient must accept. It's an order mainly which says that do not resuscitate. It's as simple as that. And it's used in terminal illnesses. An order actually has to be made if the patient has the capacity. If he doesn't have capacity, then somebody has to make that decision for him, the legal guardian. Sometimes we have seen in our setting, the relatives actually decide that we have reached our limits and now we can stop whatever doctors are doing. Yeah. Yeah, and the patient must be adult, and always it has to be in writing. We have seen that one. Doctors must be sure that the condition is terminal. There are the cases which you might think that's terminal, and what if the DNR is ordered, but the patient improves and goes home? I've seen a case where such a case, it has ended up in court. The patient has signed DNR, but he has improved. He died after 6 months. He died actually after 6 months. But it's a bit tricky if a patient has signed already DNR and then they go home. We don't know how to deal with such a situation. Yeah? Then there's a lasting power of attorney. This is just like legal guardian. It's a legal document obtained from courts. And it just says that this person, in case, for example, if a patient expects that he might lose consciousness because of certain brain, cancers, he can appoint the lasting power of attorney. And that person decides whatever happens to this patient in court, whether it is surgery, whether it is any other document, as long as they are alive. Yeah? What about children and informed consent? In Kenya, children are anyone below 18 years, but in the UK and many developed countries, they are a bit different. Children who are even 16 years can sign informed consent as long as they understand what they are going through. There's a specific case called the Gillick and West Norfolk Hospital, 1985. It was just about a lady who had six girls who are all of them below 18 years, and the local government wanted to give, contraceptive to one of the girls, and the mother refused. And she went to court. She sued the local authority because the mother was saying that the local authority they have no right to give, contraceptive to my child. And actually court ruling said that parents' consent are not required. And that is in the UK, not in Kenya. In Kenya, it's different. If the child is 16 years and above, and she understands what she is going in and cannot be persuaded, to inform her parents herself that she's getting. If the girl refuses, that she will not tell her parents about this. And she's at risk of actually getting, pregnancy and complications. Local authority, the court has ruled that the local authority has the right to give contraceptives without actually informing the parents. In Africa, we are a conservative society. This is a bit different. In Kenyan laws and child consent is very clear. Is the child below 18 years? Yes, no treatment should be given. The only exception is emergency, and that's what we stick to for now. What about mental illness and informed consent? Is a psychiatric patient, do they have the capacity? There's a very important case called RE-SB-EWHK in the UK, but also binding in Kenyan courts. A pregnant woman declined antipsychotic treatment for fear of teratogenicity. She said that maybe this antipsychotic might harm my child. Hospital relatives forced her to take treatment. She went to court. What did the court say? The fact that she was worried drugs will affect her unborn baby shows that she had the capacity to consent. And you must have sought that consent before you forced her. And actually that was a civil case. Yeah? So people with mental illness, they have the capacity to consent. The only way you cannot get that consent is that if they have active exacerbation of psychotic, manic, and depressive episodes, But if they have chronic psychosis and they're stable and they're going to town, and if you see in the document that this person has history of mental illness, do not seek consent from relatives. Ask them to consent themselves, but check their capacity. It's case by case. The content of informed consent, how is the form? We know this one. It can be oral or written. It can be expressed or implied. If it is an invasive procedure, if it's a low-risk procedure, it's always implied, oral, IV, cannula, OPD injection. These are just, we don't see consent for them. But if it's high-risk and invasive procedure, always we get expressed and it has to be written. For example, anesthesia and any form of surgery. This very important information, which has happened before, we are encouraged by courts for doctors to avoid amending the consent without the patient's knowledge. The issue is that if you amend the consent, it's null and void. And the patient didn't know. The challenge is that the gynecologists, specifically gynecologists, they always encounter this. And they go for cesarean sections, but they want to meet something else, and hysterectomy, we have to save patients. So the rule says that always anticipate, get comprehensive informed consent, and foresee circumstances, and cover with consent all these unforeseen circumstances. And this is what happened, a very important case that the patient, she declined actually cesarean section to have her unborn baby actually to save both of them. The hospital argument was that we did the surgery in goodwill to save the mother child. What did the court say? Doctor's goodwill, not a reason enough to perform surgery without consent. And you can just imagine you go in to save somebody, but you forget your legal, protection, which is, your informed consent. This is a very important case. And it's about informed consent. And it's as recent as 2018. She was tested for HIV. She turned positive. She went to court. She claimed that she was tested without consent and counseling. Hospital couldn't produce actually evidence that they obtained consent. What did the court say? The hospital committed a civil wrong of trespass to the body without authority. And she was awarded, 2.5 million. If we understand, the dynamics of informed consent, we can avoid 2.5 million is not easy money. Yeah? But you will be forced, we will be forced as a medical community to pay this money for no good reason. The best way is that we should understand medical legal aspects of every patient we are treating and actually invest in preventing medical legal instead of facing them in court, because it's very expensive to face them in court. This is another case, 2019. This patient went for anorectal surgery. The surgeon told her that everything will be fine. She develops anorectal fistula. The surgeon claimed that he informed the patient about all the complications. The court concluded no evidence. She was informed about anorectal fistula. Okay, you have informed the complications, whatever you're talking about, bleeding and infection and what, but the document you have produced, anorectal fistula as a complication is not part of it. She was awarded 21 million. They appealed, actually, they went to Court of Appeal, and it was reduced to 12 million. 12 million is a really huge amount of money, especially if you are, a hospital which is coming up. But for any hospital, is really very expensive, a very huge amount of bill. Can patients come to hospital and demand treatment? The rule says that patient has the right to refuse treatment. They can refuse whatever you have offered them, but they have no right to demand any treatment. So the antibiotic we give and all these are just goodwill, doctors' goodwill, and to keep our relationship with our patients. And we know that complications of these outpatient treatments are minimal, but definitely a patient cannot come and demand to be operated on or to be given. So that one, they have no right. Autonomy and self-determination is not extended to reasonable demands by patients. Yeah? Criminal law, consent, there's connection. Criminal law, consent. Usually, whatever happens in hospitals, if there's a dispute between a doctor and a patient, it is always a civil matter. It will not be prosecuted or investigated by the Director of Public Prosecutions, because the Director of Public Prosecutions have nothing to do with civil cases. Their work is criminal cases. But sometimes there are cases, it can look like criminal. Specifically, if you do something in the outpatients or inpatient setting, you do, for example, let's say endoscopy or colonoscopy, it never happens, in a certain setting, and the patient has not understood, and you have not signed a consent, and you cannot produce consent, and everything has been done, not professionally. The Director of Public Prosecutions can actually investigate as a criminal case called criminal negligence. Yeah? In conclusion, and this is very important, in informed consent and under ethical, relationship with patients, is that if a patient is autonomous, very autonomous to make decisions outside healthcare setting, he's an elderly man in his community, he makes decisions, is respected. They should not lose that autonomy, specifically autonomy to inform consent when they reach the hospital. We must respect patients. When the same way they are respected and they respect themselves with their dignity and value and everything, the same way they are respected outside there, we must keep that on and must be respected when they are in the hospital. I think with that, I will end it there. Thank you for listening. These are the bibliographs and the reference. Thank you very much. Back to you, Dr. Wino.
Chris, are you alive? Chris? Okay. Thank you very much, Dr. Bashir, for the wonderful presentation. You've done a very good job elucidating some of those issues that we take for granted, things like informed consent. It will be interesting, especially for my team. We are currently in the process of getting approvals for a clinical trial, and we had to actually go through some training to understand informed consent and all that. And I think you've really explained it.
Thank you, Doctor.
I need to unmute Chris. Yeah, Chris, you can now unmute, sorry. And take questions. One of the questions, I think maybe I can go, I can take the first question myself. So Doc, I remember in 2020, 2021, when COVID was really all over the place, one of the things we did in our clinic is we wrote a memo saying that all members of staff must get a COVID vaccine. And of course, there were people who were refusing. Do you think we might have breached some of these informed consent rules, or are there exceptions for such situations?
Doc, thank you very much, Dr. Koech. Actually, COVID-19 came as something surprise pandemic. It is something which has affected all over the world. It has also affected every country's stability, political, economic, and social stability. If you go back to Public Health Act, I've not included here, but we have Public Health Act. Governments are allowed by law to introduce measures as far as public health is concerned. And actually that one was under Public Health Act. For example, somebody can be forced into quarantine actually, and that's what the government has done. But also an individual, the government has insisted that nobody will be served without COVID vaccine. And that was, a national, guideline, and the government cannot decline. But the courts also, in many cases, have agreed with the government, save for few cases in which that procedure of forcing people into vaccine was done unprocedurally. For example, even if you are giving vaccine somebody, you have not respected their dignity, you have not given them information. Again, you still have to get a consent. They must sign all these documents. So the little I know is that that one was in order, but maybe somebody else can contribute if they have experience with it. Thank
you. Over to you, Chris.
Oh, thank you. Thank you very much, Dr. Koech. And thank you, Dr. Bashir, for that great presentation. Actually, quite interesting to see what happens. The courts seem to always side with the patient. I don't know, maybe you'll mention something about that as we go on. So there's a question here by Dr. Bernard Nyaberi, or by Bernard Nyaberi. He says that he's had cases of minors who are due for emergency cesarean sections, EMCS, I hope that's the correct interpretation, with no caretakers. What is your advice? And possibly I'll just lead a bit. I've seen a common practice is a senior doctor who's in the unit usually can give a consent in such scenarios in the hospital. What do you take of that? To you, Dr. Bashir.
Yeah, thank you very much. This is a very important question. We have seen some time back, I don't know if I can go back to it. However, the case was that the mother who didn't want her child not to be given contraceptives because it is against her values and religious background. But the court has said that if the child, you mentioned this about 16 years of age, if this child doesn't have any other guardian, it's an emergency. Anyway, emergency doctors are allowed to take the responsibility. But you have a case whereby she's 16 years, there's an emergency, you see, and there's no guardian. Doctors are allowed to take the responsibility unless there's evidence that there is a guardian who can take that responsibility. But by then, if the guardian now refuses this patient to undergo for emergency cesarean section, and you know that she might die because of obstructive, labor or anything, doctors are allowed to take that responsibility, be the guardian, and do whatever they are doing for the best interest of the child. Thank you.
Okay, thank you. I think that's very clear. That's quite clear. And perhaps you can go to the next question. Dr. Sirera asks, is there an entity of implied consent, or is the expectation to get consent? Is the expectation to get consent for all investigations? And for instance, if you send a patient, like you gave a good case of a patient with being tested for HIV and coming back to sue the hospital. When we send a patient for kidney tests and they come back, deranged, and it causes distress, and do we need to seek consent for all this? And is verbal consent enough, or you need written consent?
From what I have seen in Kenya, if it is in private setting, and if you are a very big institution, and this institution is non-governmental, like, government institution, in Kenya, it is good generally, verbal is allowed. For example, HIV, we do it verbal, injections, verbals are allowed. All these things, because consent, we have seen that it can be oral or written, it can be implied or expressed. If it's high risk, what we can do is that express. But these days, many hospitals are also considering what's called high risk, legal high risk, not medical high risk. If you are in Karen, sorry to mention, but these big hospitals, they are seeking actually HIV, informed consent. The patient is signing. It depends on your setting, because once the patient ends up in court, the court will ask you that, have you broken HIV and AIDS Prevention Control Act, which says that every patient must have informed consent before they are tested. But in government setting, patients are reluctant to sue because government hospitals are doing a lot of work and so on, lack of, resources, personnel, overwhelmed, all these things. For some reason, patients are avoiding to sue. But in private hospitals, they are really, really insisting. They're actually doing case-by-case assessment. HIV is one of them. They are seeking informed consent. Thank you.
Can I ask a question?
Please go ahead.
Yeah. Thank you very much, Dr. Bashir, for elaborating certain issues. A lot of times, as doctors, we consult across board, and even before we do certain procedures, the patients, obviously, we negotiate with the patient and maybe counsel them, educate them, have them sign the consent, and we agree on the management. Along the way, something might happen. Maybe the patient's condition deteriorates, perhaps even they die, unfortunately. And then you see a lot of activity arising from colleagues. Maybe your colleagues, maybe senior colleagues, maybe junior colleagues, maybe your colleagues you practicing at the same level, as to the processes that you took before you did what you did, or you administer the treatment. And sometimes it may border on a colleague criticizing or even retracting what they had or sort of, agreed to, assuming that you had discussed with them earlier on. I would like you to make a comment concerning this. What is the role of a colleague, assuming that you're practicing at the same level, in influencing or in coming in to create a scene, or else retracting the fact that they were aware about a situation and you are discussed and agreed in a manner that sets you up to a legal battle regarding the outcome of the patients that you are managing. To what extent do they contribute to the informed consent that you agreed with the patient? Some of these colleagues sometimes are relatives to the patients. I just want you to make a general comment, because I think occasionally colleagues begin to have an influence on the way the patient is even able to be treated or guided to treatment, or sometimes in the way they handle the outcome, especially when the outcome is negative. Thank you.
Thank you very much, Doc. Here, the way I understood is that you have planned for a patient, you have given treatment, they were given second opinion, and that second opinion might be has put you in a bad light, and now the blame is on you. You might have
that committed. Is it. Yeah, exactly. And this second opinion usually comes once one of the negative thing, one of the probably adverse outcome has happened, and even if you had explained that adverse outcome to the patient, and then it is like a colleague now sets you up. What is the role of colleague really in the process of managing a patient, especially where you feel like you are competent enough to handle that situation from the beginning? Because we see this a lot, I think.
Yeah, Doc. Yes, I get you very well. So the issue here is who is complaining here? If the patient complains, the court will ask, the contract, who was it? Was it between the colleague or between you? Whatever was done, surgery, that surgery, who has signed the consent? Whatever was done, treatment, that contract, was it between you and the patient or between you and the other colleague? If something bad happens, the court will ask, who is the doctor? They will not ask what has happened between you and your colleague. That is internal, actually, generally, and more of ethical, actually, because here we are talking about ethical versus legal. It doesn't mean that everything unethical is illegal. There are some unethical things which are legal, like I'm saying. So the issue is that here is more of less internal issues that can be actually handled by hospital disciplinary committees, discussion among colleagues, but at the level of courts, they will not bother to enter that actually what has happened in internal politics. They will ask that, who is the doctor treating the patient? Who is the patient? Where is the contract? Is the informed consent? Then they want to identify something called liability. If the court decides that it's your colleague who has given the second opinion is liable, then they will actually have to go after that. But mainly it is between you and your patient and the court. Your colleague was given second opinion, actually, or even verbal second opinion, or has put you in bad light. Usually that one is just the internal politics. The courts, usually they are not involved. Thank you.
Fairly answered, thank you.
Great. Thank you, Dr. Koech, for that question that brings a different dimension to this topic, and how other colleagues, our interactions with other colleagues can expose medics to litigation. So there's actually two questions, Dr. Diana Mwangi and also Dr. Njuguna Mwangi. They ask if, and I saw that in your presentation, if we can decline to provide care to a patient. And maybe if I can add a twist to it, if, for instance, a patient demands a certain type of care and you decline, and the patient goes on and gets some sort of morbidity, are you culpable for that?
Doc, if a patient is under your care and you decline to treat, by the courts of law, you cannot abandon them. You can decline, but you cannot abandon them. There's a difference between the two. You must hand over to another doctor. Even if you are bitter with the patient, not happy, you have declined, they have disrespected you, they have not paid for your services, still the patient is under your care. And if he has gone to court after you have declined, there's a problem there. But you must show an evidence. You must show an evidence that you have handed over the patient to another court. That means responsibility shifted. Although the reason why you have declined, the reason why you have transferred is you have declined to treat this patient. You can decline, but you cannot abandon them. You must transfer to another hospital, to another doctor. You must sign all the documents. You must sign that you have called this doctor, so-and-so consultant, this hospital, in documentation. The person must actually, you have signed all of that in your writing. That one, you have covered yourself legally. But if you actually, the patient has been under you, and you tell them, I'm not going to treat you from treatment, they can go to court. Breach of contract. We have seen informed consent and treatment giving between hospital and doctors, between hospital and patient, doctor-patient is a contract. Each party must perform their contract to its conclusion. That's what the court will say. If you have declined, you must give a reason and must transfer the patient to another doctor. Thank you.
Thank you very much. So in short, you mean prevention is better than cure. So you just need to make sure you document clearly and every step, and make sure that the patient has been transferred to care of another person. So Dr. Caroline has a comment, which is, from this presentation, it is clear that there is need to change and improve our consent forms and include complications, and have these consent forms, detailed consent forms, not only in surgical wards, but all around the hospital. A question that follows from her is, how do you prove that you obtained informed consent in court? For instance, especially in the cases where it is verbal, say in a public hospital, but also you can advise in the ideal case how we can prove that.
Usually, legally, informed consent is proven by production of a document. The courts also know which procedures generally doctors are supposed to obtain informed consent. The courts will not bother you to produce informed consent for IV cannulation. But if it is a surgery, you must have informed consent. You must have saved that record, kept it somewhere. And actually what is more important, that it must be legible reading. I've seen a court case whereby a patient went to court, the hospital producing some not informed consent, but the documentation. The court could not read. Anything they cannot read, they rule against you. So doc, in short, the only way we can prove in court is just the documentation. Anything not written, as we say in legal, jargon, anything not written, not done. The court is the same. Anything not written, not done. If there's a document, you must produce it. But they will not ask you, like implied, major procedures. That's what I'm thinking. But anybody who has experience here, please also can contribute that. Thank you.
Let me ask another question.
Yes, Dr. Poet, go ahead.
Yeah. So this happens quite often. Even here where we practice, actually, sometimes I'm a physician, and then there's a time I was rounding at Amenity, for instance, and then while I was at the parking lot, somebody grabbed me. A theater nurse, actually, not even a theater nurse, a nurse who was superintending on that weekend, and told me there's a child who has been brought for emergency debridement, actually amputation of a leg that was necrotic following some incident. in the ward. I think the tourniquet had been forgotten, something like that. So I went in, I saw the child. Really, yeah, it was ischemic limb extremity. It was actually already completely non-viable. And they needed a consent to amputate. And I can't remember the circumstances because the mother was there, but I think, yeah, I can remember the mother was a minor. The mother was by law, you know, the mother was 17 years, I think 16 years. And since the surgeon was being waited and the patient had been wheeled brought to the theater, okay, they wanted a doctor to sign the consent. Okay, I ended up signing. And then later on, I thought, I don't know much about the history of this patient. And I didn't retract the consent. I didn't go back to say, okay, let someone who was managing this patient or the surgeon is going to do the amputation or something like that, do it. I just proceeded on to sign the consent, but after examining the patient and noticing the limb was ischemic and so forth. Now, that's a very practical thing that I've done. Is it right? Because later on, I was taken aback and I was like, have I done something that I'm supposed to be? I'm a physician in the first place. I'm being called, I'm signing a consent in theater for an amputation. The mother is a minor, the child has had an incident and so forth. Just a practical example, respond. What should is there something that I should have done a little bit different? Thank you.
Doc, thank you very much. As you said, this is a very practical example. A minor who needs emergency care, whose only guardian is another minor. In our setting, and actually the courts will not crucify you. In our setting, doctors can be the guardians of minors who need special emergency care, as long as that care is being done for the best interest of the child. And that's actually according to the Children's Act. If I'm not wrong, actually we have Children's Act 2011 and the Constitution and ethically. So the exemptions actually to informed consent given by a patient is special situations whereby the person is a minor and they need emergency care. Doctors are allowed to act for them if we cannot get a legal guardian. Sometimes children's, facility care, the managers are in some situations, they are the legal guardians. If you cannot get a sponsor, if we cannot get a person who adopted this child, if we cannot get another adult, and this emergency, how long will it take for us to get a legal guardian for somebody who needs emergency surgery? Doctors are allowed, it has happened, but I've never seen such case going to court. It's very rare and it may be impossible. Courts will really throw away such cases because doctors act for minors who need emergency care for their best interest of care. Thank you.
Okay, thank you very much. So yeah, I remember actually, so the surgeon had signed, but they needed someone else also to sign because the mother was minor. So they just didn't want the surgeon who was going to operate to be the one signing at the same time on behalf of the mother. So that is how I got into the mix. But thank you for responding. Thank you.
Yes, great. So very practical approaches on how to tackle issues around consent in the clinical space. So I believe we should be wrapping up. However, we have a few questions we'll take and then take one or two questions live on audio. But before that, Dr. Bashir, I got a question regarding blood transfusion. So that Dr. Chege Evelyn Chege asks that there are 16-year-olds and above who are in secondary schools or high schools. Usually the head teachers allow for the blood donation drives. So if, for instance, you're a doctor and you're working with a blood transfusion unit and you're involved in such a program, is it okay to just work with the assent, or should one seek consent from parents or guardians before blood transfusion is actually blood is donated from this 16-year-old?
Yes, Doc. This is very difficult also, because I've seen so many children from schools donating blood, but I've never known the arrangement. And the question is that, do we need consent for blood transfusion, or do we need consent for blood donation? In most cases, what I have seen, literature-wise, medical legal aspect in textbooks, donation, you might not be required to have consent when you are donating, but transfusion you require. That is the medical legal circles. But you have a child here. I need to update myself in the laws in Kenya regarding high school children donating blood. I'm sure usually Kenyan Blood Transfusion Center is the one who organized that, and they have their own legal people who they consult. And that one actually, as far as law is concerned, that 16-year, 17-year-old, we have seen before, who's actually contributing to the nation in terms of people who need urgent blood transfusion somewhere else. There might not be any specific. The only thing they do is that certain documents, blood transfusion document, which they sign, and that sign, the 17-year or the 18 years, they sign down there after, have you accepted, after they have done the vitals, blood check, everything was checked. The document, if you check it down there, it says, have you accepted? And there's a signature somewhere there. 17-year-old, according to some, countries, they are allowed. In Kenya, most likely they seek permission from parents, although that permission might not be written, but they seek permission. But generally, blood donation, you are not required to have any consent. You only have to have for transfusion. Thank you.
Okay, thank you, Doc. Thank you, Doc. And probably the last question from the chat is by Dr. Sirera. She asks, in our setup where we don't have very clear, precedence or clear tradition to give legally accepted instruments for someone to make a medical decision for you when you don't have the capacity, what really takes? Is a decision by a next of kin who's not identified as a surrogate decision maker valid?
Thank you, Doc. If a patient doesn't have legal capacity, here we are talking about legal capacity, two things only. Age of majority, is this person adult? If they are not adult, then they don't have legal capacity to consent, especially in Kenya. Or adult of sound mind, is their mentation okay? If their mentation is not okay, then you ask yourself, do they have legal guardian? In our setting, the relatives are always legal guardian. And sometimes it's not something which has been pre-arranged. Someone comes, a gentleman with dementia, you might need this, some urgent procedure, and you ask, this person who can sign? And the son says, I can sign. The court accepted that. But in certain, elite centers or setting, a gentleman who knows that he has brain cancer, and at one point he will get, his level of consciousness will go down, dementia and all these things. They usually get a legal representative, not necessarily a lawyer, in advance and in writing. And that person comes with a document, actually, produces that. Sometimes they don't have to be their relative. The person can choose whoever they want. Some of them, they are lawyers, they are friends. So if the person doesn't have the capacity to sign, the setting we ask, is it adult or a child? A child, parents will sign. Adult, we ask who can sign for him. If it is close relative, usually we sign it, you know. It's nice to ask if they are relative and identify properly, because sometimes if it ends up on a court and that person was not their relative, and you know, you feel a little bit awkward, you know, the court can tell you that you have not done your due diligence, yeah? But mainly the court accepts our relatives, our brothers, mainly our wives, to be our legal guardians. And if the person or patient has already identified when he was okay and walking, that this is my, just the same way they make their will. You know, somebody, when they are making their will, they also make their legal guardian. When I lose the consciousness, this is the person who's, and there's a document, that person can produce that document. So doc, that's what I'm thinking. Thank you.
Okay, thank you. So just need to do your due diligence and know that you're dealing with the right person who's above 18 years of age. So I see Collins has been having a burning question, and Imran. So we'll take Collins's question, then Imran, as we wind up on this very, very interesting and thought-provoking session.
Thank you. Mine just ties up to, I think, the question by Caroline on what is proof of informed consent. I don't know if Dr. Bashir had read, there's a case, I think that a judgment was delivered sometime in December by Justice Mrima, LAW and two others versus, I think it was Marura Maternity and Nursing Home and three others. So basically the background was, this was a lady who got pregnant in routine ANC, tested, became HIV positive, but somehow managed to undergo BTL. So the case ended up in court. The issue was this lady was from a low socioeconomic status. I think she dropped out in primary school or something, class 4 or something. So the judge was of the opinion that this lady, because the hospital on their point was like, we obtain informed consent. They even produced the informed consent form, the signed one, to court. But the judge, Justice Mrima, said that is not enough. This is a lady of from a low socioeconomic status. She's not well educated. So over and above providing the signed informed consent, you need to produce proof of how the informed consent was procured. So I don't know what the comment of Dr. is, because now that, you know, that introduces another step of informed consent, particularly in people of, of people of low socioeconomic status or people who are not well educated. So doctors need to produce proof. So I don't know what your comment on that will be. Thank you.
Thank you very much. And actually, this is very, very delicate, because, as I was saying before, Doc, that informed consent is not just patient saying, yes, I have accepted. It's a process. It's not an event. The court will ask you, yes, the first part of the process you have gone through and you have produced the document. The question that I will ask you is that, did the patient have capacity to consent? And the hospital said, yes, this is the form. The next thing the court will ask you is that, did the patient exercise that capacity to consent? And that's where legal blind spots actually comes in, and that one it's left to the interpretation of the court, because unless you have employed, people who do medical legal, specifically risk managers in medical legal, it is very difficult just to sign each and everything. For you get the document and you sign. But the court will ask you is that, did the patient understand what is PTL? Where is the evidence? Not the consent. Have you explained to her in writing, in a language she understood, she understands? Think about it, and you must document in writing that I have explained to the patient PTL at this time. I've given the document. I have informed her. You write actually You can hear me?
Yes, Doc, I can get you now. Can proceed.
Yeah, so in summary is that has the patient had capacity, did they have the capacity, and have they exercised? So in conclusion is that what the that exercise of capacity, and you have to prove it, is very difficult. Sometimes we leave it to courts to decide. Thank you.
Okay, Dr. Bashir, we lost you a bit there.
Yeah, thank you. So I had a small network, but I was saying that usually the court will ask you if you have the capacity, and if there's the capacity, have they exercised? That's what I was saying. Thank you.
Thank you. And I believe that includes using language that the patient really understands when you mentioned the BTL. So thank you for that. Imran had a question. I'll take this as the last question as we wind up.
Thank you, Dr. Chris. Thank you, Dr. Bashir, for this informative presentation. I had two questions, but I think I'll just put them as one. In terms of decision made by next of kin as surrogate decision markers, what's your take on DNR that is actually signed by next of kin and not by the patient themselves? That's number one. And then number two, in terms of religious implications, like I saw a slide whereby you were talking of a person is actually has a right to his religious beliefs. And let's take for an example, Jehovah's Witness who actually refuses or he's against blood transfusion, but then he goes under, let's say he goes for a surgery and then the surgery complicates, he bleeds a lot and he ends up needing blood. And the next of kin actually accepts or actually gives consent that the husband or rather the relative can receive the blood, but then the patient themselves, they had refused, or you know that they are Jehovah's Witness. How do you go about that? Thank you.
Thank you, Dr. Imran. DNR, who can sign? The patient himself, if he has the capacity. If he has the capacity, they sign. If he doesn't have the capacity, the next question is that, is there legal guardian or somebody he has already identified? If there's legal guardian, the legal guardian will sign. If he has already identified legal representative before even we go to this, lack of capacity situation, then that legal representative will be the person who will sign. Yeah, DNR is just like, is another form of consent whereby you either sign the consent for yourself or somebody signs for you. When somebody's signing for you, you lack capacity. That is the one. Then the one for Jehovah's Witness is a very controversial topic. It is a bit difficult situation. A person who has an HP of 3 and they are declining to be transfused. What are you going to do? If the patient dies, you are in trouble. If you give them blood transfusion, you are in trouble. Actually, it's a bit difficult situation. However, in courts are of the opinion that patients have gotten so many rights, and one of them is the right to die. If they sign for it, and actually when they're about signing for them, there must be witnesses, a lot of witnesses. Yeah? If you're a private hospital, you can even include your lawyer. So Jehovah's Witness is a bit very controversial topic. That's how I conclude. Thank you very much, Doc.
Thank you very much, Dr. Bashir. I'll ask the host, Kennedy, would you kindly mute for us? Baraza, mute for us, Dennis Kobina. Thank you. Thank you very much. So I believe we've come to the end of this CME. this evening's Oxtree series CME. And it's been quite an interesting evening, packed with a lot of new ideas, new perspectives regarding consent, and just leading us to a reflection that there's a lot that needs to change on our part. Not only in the direct clinical practice, but also for those of us who are in healthcare entrepreneurship. Dr. Bashir, I'll just hand it back to you to give us a parting shot, and then we can close the meeting with a word from Dr. Koech, Dr. Matthew Koech.
Thank you very much, everybody. My parting shot is that medical legal discussions and medical legal practice is a very, important topic that we cannot ignore as long as you're a physician practicing in Kenya. And actually, it has to be included. That's what I'm thinking, even medical school curriculum, that for us to understand how to avoid legal issues and avoid courts, we must understand the law around medical practice. That's how I will conclude. Thank you very much.
Asante sana, Dr. Bashir. And Dr. Koech, to you to give us your closing remarks for this meeting.
Well, unfortunately, I'm in a supermarket where it's a bit loud. I don't know whether the background noise is too much or it's okay.
We can get you very well.
Yeah. So I think I'm very, very happy with the presentation made by Dr. Bashir, especially because I remember some of the training I went through in our lead up to our, to our clinical trial, and we had to learn about informed consent. And I really remember that bit about consent being a process, not an event. And that's very important for most doctors. Sometimes we forget and we just tell patients, sign up. So thanks, Doc, for reminding us and for teaching us. And we really, really appreciate that you came up, requested to give this talk. And that's very impressive. I see there's been a lot of demand. So we'll organize again, Daktari, for you to give this talk. Maybe in this forum or in another forum, because we're seeing a lot of requests by people who missed out due to the limitation of the 100 participants limit on Zoom. But we're going to work on that. We will improve our limit maybe to around 300 in future. And we'll see a way that you can make this presentation again to another audience or the same audience. So thank you very much, and we really appreciate. Thank you for all the participants for coming. We're going to provide your CPD points within the next 2 hours or 3 hours or so. And you're also welcome again in 2 weeks.
Thank you, Doc. Thank you very much.
Okay. Great, Asante. And see you in 2 weeks' time. Till then, have a great evening and all the very best.
Thank you.
Thank you, Chris.